care nursing. She later served as a supervisor and then director at Continuum Pediatric Home, demonstrating a natural talent for leadership and program development. Despite her administrative success, she found her true calling in education and transitioned into academia, serving as the lead professional at Chamberlain University. Currently, Dr. Coker is a professor at German Community College, where she is committed to shaping the next generation of nurses through mentorship, education, and empowerment. At the same time, our enduring love for bedside care drives her to continue practicing as a child nurse at Mary Washington Hospital. Our clinical expertise spans women's health, pediatric, critical care, and cardiac nursing, bringing both breadth and depth to a world role in patient and education. With a family lifelong and compassionate care, Dr. Coker continue inspire excellence in every facet of nursing she touches. Ladies and gentlemen, Dr. Georgina Coker. All right. Next is the co-host. It is with great joy and honor that I introduce to you the co-host for this event, Mrs. Jacqueline Abdullahi. Mrs. Abdullahi is a licensed clinical social worker and a registered nurse. She holds a master's degree in social work and brings 18 years of experience in the field, along with over 12 years of hands-on nursing experience. She currently serves as the nursing supervisor with the Fairfax Falls Church Community Services Board and is also a clinical instructor for behavioral health nursing at George Mason University. Throughout her career, Ms. Abdullahi has offered expertise in clinical assessment, crisis intervention, using a client-centered approach, service plan, development and review, and motivational interviewing to engage clients effectively. Her approach emphasizes meeting clients where they are and empowering them through supportive, individualized care. As the nurse supervisor for the intensive community treatment programs, she has been consistently recognized for her ability to advocate for program needs, build strong rapport with shareholders, and train nurses to be both practical and efficient in their work. Ladies and gentlemen, Mrs. Abdullahi. Okay, so I'm two hosts here. I think this is the end of my job.
Hello. Good afternoon, ladies and gentlemen. Welcome. I'll be giving you guys the opening statement. Good afternoon, everyone, and welcome to the Community Health Symposium, hosted by the Plant-Based Association in partnership with the African Wing of the Woodley, Virginia State of the Church of Jesus Christ of Latter-day Saints. Today, We gather under the theme addressing suicide crisis, stroke, diabetes, heart disease, and health and wellness, and do not forget autism. This symposium is designed to bring awareness, education, and resources to our community. Together, we can make a meaningful difference in the lives of individuals and family. We are honored to welcome a distinct panel of experts in neurology, psychiatry, cardiology, physical therapy, and primary care. They will be shaping your knowledge and strategies to promote healthier living and stronger community. This event is free and open to the public, and we are pleased to provide complimentary snacks as we learn and fellowship together. We believe that by combining our efforts, expertise, and compassion, we can build a healthier, stronger, and more resilient community. Thank you for joining us today. Let us look forward to an engaging and impactful symposium. Thank you. I'll go ahead and introduce our first presenter, Ms. Crystal Hackman. Currently works as a nurse practitioner in inpatient neurology. She graduated in 2009 from Amity University with a Bachelor of Science in Nursing. Crystal has worked in many areas of nursing, including rehabilitation, home health, insurance case manager, medical surgical, and step-down ICU. She returned to school in 2018 and had a Master of Science with a concentration in adult gerontology, acute care nurse practitioner from Virginia Commonwealth University in 2020. She transitioned from bedside nursing to a provider role in December of 2020, working in the observation unit at the Washington Hospital. After gaining experience, she transferred to inpatient neurology in May of 2022. She currently works with patients suffering from neurological disorders. Ladies and gentlemen, Ms. Crystal Agnew.
Okay. So my name is Crystal, like she said. I work in patient neurology at Washington Hospital. I've been there in that particular position since 2022. I've been with Mary Washington since 2017. Started to get 5 months there. I've been an RN since 2009. So Georgie asked me to speak today about stroke. So please bear with me. I am not great at speaking in front of crowds, but we'll get through this. So first, has anybody here been affected by stroke? Okay, so you know the devastating effects of stroke. So I kind of want to just touch base on some of the background of stroke, but most importantly, I'm going to talk about ways to prevent stroke and signs and symptoms to look for so you can get timely management and care about coming to the ER when you have them. So what is a stroke? A stroke occurs when basically there's a lack of blood flow to the area of the brain. These same symptoms happen when you have what we call a mini stroke. But with the mini stroke, those the blood flow is restored typically within 24 hours. So with a mini stroke, you don't see the signs of the stroke on an MRI as you would with the actual stroke. when this lack of blood flow happens, you basically have cell death to that area that has been affected, which is why you have symptoms of the deficits left over after stroke. This is just some statistics on stroke. On average, someone in the U.S. dies from stroke every 3 minutes and 11 seconds. Stroke is the 5th leading cause of death in the United States. 3rd leading cause of death in women. Black adults have a higher prevalence of stroke, an estimated 4.3% of Black adults reporting history of stroke versus, compared to 2.7% of white adults. Up to 80% of strokes may be prevented with lifestyle changes. Hypertension being one of the biggest risk factors for stroke. And then more than 2/3 of stroke survivors will have disability after suffering stroke. So what I was just mentioning on, so TIA, which is what we call mini stroke. Patients that present with TIA have the same exact symptoms you would have after stroke, but your symptoms will resolve within 24 hours. Like I said, that's a temporary interruption of blood flow, which is why the symptoms will resolve. Anytime a patient presents with a TIA, that's a warning sign. That's letting you know that something needs to change before you actually have a big stroke. So that's a perfect opportunity for patients to get risk factors under control, for instance, blood pressure, cholesterol, diet, weight, smoking cessation. All those things play into stroke. So if someone comes in with mini stroke, those are things that we send them out to work on and to follow their primary care providers to hopefully change and prevent. Ischemic stroke is when we have this interruption of blood flow. That's usually caused by some form of clot or stenosis, which is narrowing of one of your arteries that goes to the brain. Meaning your carotid arteries are the arteries throughout the brain. Those become narrow because of plaque. Heredity, people can be born with an issue like this. But that's what causes that blockage. And then hemorrhagic strokes. That's when you have a weakened blood vessel that will rupture. It can be due to an aneurysm, what we call an AVM, which is the malformation of those vessels. Usually can be provoked by extremely high blood pressure. That's usually when we see patients coming in with these bleeds, having controlled blood pressure. So causes of ischemic stroke, that's what I really want to touch on today, because that's typically what we see in ischemic stroke. It's rare that we see hemorrhagic stroke come in. But the cause is what we talk about, clot. So a thrombotic stroke is usually caused by a clot that's within the blood vessel inside the brain or in the carotid artery. Embolic strokes are caused by clots or somewhere else. Typically, we see embolic strokes for patients that come in with the new onset of what we call atrial fibrillation, an irregular heartbeat that a lot of times patients don't know that they have. Without being on a blood thinner, anticoagulation, and a history of atrial fibrillation, it sets you up for a stroke, which is why we do a complete workup when you come in to rule AFib out in these patients that we think may have an embolic stroke. The reason we know that it may be embolic, the presentation of the stroke on an MRI. These providers know what may be an embolic stroke versus just a what we call a lacunar infarct, which is usually caused by uncontrolled risk factors, and those are strokes that happen in the deep obstructions of the brain. And then a cryptogenic stroke means that a patient has come in with a stroke. We've done all of the work, but we can't find the cause of the stroke. So with those patients, we normally send those patients out to what we call a loop recorder, a small device that will implant to look for AFib. I mean, it can take a couple of years actually to find out if a person actually has AFib. So that's just the patient will leave not knowing why they had that stroke. So at that point, we just control risk factors. We look for AFib to make sure that that's the cause, and they hopefully can try to live like as normal as possible. Risk factors, modifying risk factors. Number one risk factor is hypertension. Working inpatient, I see a lot of patients coming in with uncontrolled hypertension. A lot of the patients know that they have hypertension. They'll stop taking their medications for reasons due to side effects. I'll see, not pointing any population out, but I'll see a lot of African American men who will stop taking it due to side effects, due to erectile dysfunction. Some people will have certain antihypertensive cause, some edema or swelling in the lower extremities. But I need people to know that these things are things that you can talk to the primary care provider about. If you're having side effects with one particular medication, there are other medications that can be tried. So you shouldn't just stop taking your antihypertensives, because it could lead to, a large stroke. Diabetes is another one. With stroke, we like patients who are diabetic have an A1C of 7 or less. Again, we see patients coming in not taking their diabetes medications, not taking their medications frequently, or just not following up. But that's another huge risk factor. Smoking, high cholesterol. With stroke, we look at what we call the LDL, which is the maximum fall. Typically, for the average person, we want it to be 100 or below. For a stroke patient, we like to keep it of 70 or below, which is just a little lower than everybody. Physical inactivity, obesity, and diet. Non-modifiable things, obviously, age, family history, genetic factors. All right, signs and symptoms of stroke. So, typically with a stroke, you have symptoms usually on one side of the body. It could be numbness, tingling. You'll develop weakness on one side of the body, facial droop. Sometimes you will have, it's typically not a loss of speech. It'll be issues with getting words out, or you'll be able to get words out. They won't make sense, but you won't be able to understand what someone is saying to you. So someone around you will be able to notice that. With the facial droop, some people develop slurred speech due to the muscle weakness in the face. With the vision, that usually means that you're having a stroke kind of in the back of the head here in the occipital area. You usually either have loss of vision or a visual field cut. It's typically not blurry vision. Anytime somebody comes in and says they have blurry vision, it's usually something else. Sometimes you'll have double vision with the stroke, meaning that you'll have paralysis of one of your eyes, meaning they won't move together. Somebody else will probably notice that. So double vision, loss of vision completely in one eye, or a visual field cut, meaning half of your visual field is gone. That's usually an indication of stroke. This is one that's missed often. People come in with dizziness. So dizziness could be just vertigo, which is just, dizziness, kind of people have nausea, vomiting, just kind of ache and instability. But if you have other things going on with the dizziness, or if the dizziness is not positional, meaning if you're lying down and you sit up and get dizzy, if you're up and you're just completely dizzy, regardless of the position, then and you have stroke risk factors, then you should be concerned about stroke. So dizziness, loss of balance, coordination is another one. If you're noticing that you're trying to take something and you're overshooting, or you can't manage your phone because you can't, I guess things will seem out of focus when you're trying to touch your phone. Those are usually signs of a posterior circulation stroke. Those strokes are missed often when patients come into the emergency department because they automatically think that it's vertigo. So that's just something to be aware of. When you go to the emergency department, you go in and say, I'm dizzy, make sure you let them know everything that you're feeling, because you are your own advocate. I mean, they're going to automatically assume it, but your body better than anyone. So if you go to the emergency department with these issues, and this is not your baseline or something you've never felt before, you make sure you advocate for yourself. This little acronym here, VFAC, this is just something to remember. It was just bad, but they added the balance from eyes to a balance because of what we just talked about. Always missed for this posterior circulation stroke. B is for balance, eyes, like I said, you have this visual field cut, loss of vision, facial droop, arm weakness on one side, speech difficulty with the slurred speech, mixing up words, and then time is brain. Call 911. Don't wait to see if the symptoms are going to resolve. You develop these symptoms, call 911 immediately. I have so many patients who will come in and say, my symptoms started yesterday morning, but I waited and went to bed last night to see if they were going to resolve. If you come in immediately, there are treatments that can be given if you're there within a certain time frame. Diagnosis. So clinical evaluation. When we talk about the medical history and physical examination, those two are really big in patients with the TIA or a mini stroke because those do not show up on imaging. So we need a good background history to be able to diagnose you with a TIA or a mini stroke versus some other illness. We don't want to give you a diagnosis that's not what it is, which is why we need a good history. Neurological testing, which is just a test that we do when stroke patient comes in that kind of gives us work to look at the severity of the stroke. Imaging studies. When you initially come into the ED with stroke, we always do a CT of your head to make sure there's no bleeding. And then we look at a CTA of the head and neck to look at those vessels, arteries, the arteries throughout the brain to make sure you don't have an occlusion of one of your large arteries. If there is an occlusion at that time, that's when we talk about sending patients out to have what we call a thrombectomy if you're within a 24-hour time frame. They can actually remove the clot from patients that are good candidates for this to hopefully restore some of their deficits that may come in with. But that's up to the provider based on when the time of symptoms started and the time that you come into the ED or emergency department. And then the MRI, all patients who come in with stroke symptoms will be admitted to the hospital for a complete stroke workup. And then we'll do the MRI just so we can take a look at the stroke burden, how much stroke or how big of a stroke that you actually have. Acute treatment is what I was talking about. So anytime you come in, we always give aspirin and Plavix. Especially if it's within 24 to 72 hours, we'll give you a high dose. We'll give 24 of Plavix. So both of those are antiplatelets. We give the doses of the two different ones just because it gives you a better chance of recovery. Thrombolytics, T and K is the medication that I was talking about. So if you start having symptoms and come to the hospital 3 hours later, if you come in that 3 hour time frame and you have significant deficits, T and K is a medication, it's called a clot-busting medication. You can receive that medication if you're there within 4.5 hours, as long as you don't have any contraindications. Meaning you can't just have surgery, you can't be on an anticoagulant like warfarin or Eliquis already. But this medication can be given if you're there within the time frame. It just gives you a better chance of recovery. And then I just talked about the thrombectomy. If you have a large vessel occluded, we can send you out to have that removed if you are candidate. This just talks about medications post-stroke. Anybody who comes in with a stroke or mini stroke will be sent out on an aspirin, 81 milligrams that you'll take indefinitely. Usually reserved for patients that are newly diagnosed with atrial fibrillation. And then a statin, which is cholesterol medication. That's also part of the stroke protocol. Most patients will be sent out on a statin because they're allergic to it. Some patients will just refuse it, and we'll just recommend diet, but our goal is only to be the health. Prevention, we kind of touched on it already. Exercise. So just daily activity, I can't remember the daily amount that the American Heart Association recommends. But just walking, daily activity, I would say at least 30 minutes a day. Practicing a Mediterranean diet, weight management, smoking cessation. Smoking cessation is huge. And then blood pressure control. I would just make sure for anybody, following up your primary care doctor often have blood pressure checked. If you notice that your blood pressure is elevated, I've had this happen to me. My blood pressures were slightly elevated, and monitor, just know that that could be doing damage to your heart. You need to, again, be your own advocate. I told them to put me on the antihypertensive because my blood pressure is running, you know, on the lower side. If you know that you're not a person who's going to be out there and change your diet immediately or lose weight immediately, yeah. And make sure you're following up with your doctor to monitor the numbers to make sure those medications don't need to be adjusted. Cholesterol, that kind of goes along with diet and weight management. Diabetes control, make sure your doctor is checking your A1C at least every 3 months. And then regular health checkups. Make sure you're touching base with your primary care provider. Again, this just goes into the managing hypertension recommended. For stroke patients, we recommend less than 1/3 over 80 is the long-term goal for our stroke patients. While they're hospitalized, we want to manage after the patient comes in with stroke, we want to keep the blood pressures within range because elevated blood pressures will make you bleed into the stroke. It'll be a hemorrhagic conversion. You don't want that. You don't want bleeding after a stroke, which is why we have to keep a really close eye on after stroke when you're hospitalized. The same when you go home. Patients will go home and be non-compliant, and then they'll come back with hemorrhagic transfusion. You still have to manage the blood pressure once you get home, meaning you need to be checking blood pressure at least twice a day and following up with your PCP immediately. Following your prescribed medication, taking your aspirin every day and your statin. Once you're discharged with the stroke. And then this just says that uncontrolled blood pressure is basically leads to poor outcomes. Rehab after stroke, patients with significant deficits will touch base with physical therapy, occupational therapy, and speech. And at that time, they'll make recommendations on what should happen after discharge, whether the patient should have outpatient therapy, home health, or either acute rehab. Usually for patients with deficits, we always recommend acute rehab, whether they're there for a week or 4 weeks. Acute rehab patients seem to do better when they have acute rehab. And then stroke support groups. People who have strokes, you know, those patients usually suffer from depression, you know, just having to deal with dealing with a new way of life. But there are stroke support groups out there in Washington. Actually, have stroke support groups once a month. But that's something also to keep in mind for patients or family members who suffer from stroke. And again, time is money. So if anybody in your family or you have suffered stroke symptoms, sudden onset, don't wait. Call 911, emergency room, and you be checked out immediately. We talked about a requirement intervention, whether it's T and K, whether it's the dual antiplatelet therapy given at one time initially, or whether you have a large vessel occlusion and you need to be sent to have a procedure where a mechanical thrombectomy is done to remove that clot out of that clot. And then learning the signs of stroke, you can help yourself and
If you have a question, you can just stand up. Any questions?
Some things we can do for people that may not be all that global. What are some things that we can do to mitigate?
well, the biggest thing is blood pressure. If they're not mobile, if they are making sure they're not within the appropriate limits, make sure they're taking their medication, diet is a big thing. Make sure they're eating a part-time diet. I don't go into all the weeds with it. I can tell my patients to have lean protein, to have vegetables, and a simple coffee. Make sure they're drinking plenty of water, not drinking much sugary drinks, and having much snack. And I'm not telling patients not to have snacks and not to have desserts because that will be sent to a facility. Everything in moderation. And then if they're not mobile, you can still do, it will be more of a physical therapy type thing, but you can still do activity. If they're in a wheelchair, they can still do leg marches sitting there. You can still do men weights, you can do resistance bands, a lot of things you can still do for activities.
Here's another thing would be like for those of us that fly, what are some things that we can do in the plane that can reduce the risk of having a stroke?
Well, if you're a person who does not have a high risk of stroke, flying on a plane, I wouldn't think that it would put you at a high risk. But if you're sitting for a long period of time, make sure you're getting up, moving around throughout the plane, wear compression socks while you're moving. I mean, I wear compression socks. But yeah, if you're not at high risk and your doctor says that you need to be on anything, being on a plane wouldn't put you at a high risk. Okay, you're welcome. Any other questions? So I guess I would ask, what are their? For what?
Pulmonary.
So I would prefer that their pulmonologist or to hematologist. At some point with clots. Sometimes the pulmonologist or the hematologist will take them off. Sometimes they'll say they need to be on the long term, just depends on the patient's background. Okay. Any other questions? Thank you.
We want to thank Ms. Bristol for being here and educating us. When the whole symposium is done, we set up tables for people who want the blood pressure exam. And we have some nurses students that can help us out. Now we have a table on the right of us. They can do your blood pressure right now for you for free. So thank you, Ms. Bristol, for empowering us. Hopefully we can take the tips that she has given us to utilize it in our daily life. At this point, we are transitioning to mental health. And it's